Okay, good noon to everybody here in person as well as those who are joining us on Zoom. It is my pleasure to introduce Dr. Marisa Raymond Flesh, who is going to be talking about her project, the development of SPANYA trial, how qualitative health disparities researcher came to run a clinical trial of psilocybin to treat anthrax nervosa. Dr. Raymond Flesh is an associate professor in the Philip R. Lee Institute for Health Policy Studies and the Division of Adolescent and Young Adult Medicine within the Department of Pediatrics. Clinically, she practices in adolescent and young adult medicine with patients 12 to 26 years old, including the treatment of depression, anxiety, and disorders, providing all types of contraception and providing primary care for patients with complex medical and mental health conditions. Her research focuses on access to care for adolescents and young adults with particular interest in improving mental health and reproductive health care for minority and rural communities. She's currently designing a clinical trial to test the use of psilocybin-assisted therapy for the treatment of anorexia nervosa in young adults. She's especially interested in using community-based participatory research to design meaningful research projects and create health interventions for the communities want and that they need. So thank you so much, and please give her a warm welcome.
I really appreciate the opportunity to speak today, and this is almost a works in progress sort of brand now. I'm going to share the story of how this study came to be and what we're hoping to do with it, and really welcome thoughts and feedback from the community at IHPS. I really value your input along the way. You guys have informed a lot of what we're doing. And just where we're headed today, I'm going to start by sharing some information with you about how I came to my and I originally drafted one version of this talk to share with Dan Dohan's group. And so it is a bit of a story. I am a qualitative researcher. And I will tell you some about anorexia nervosa. You know, sure, colleagues at IHPS, not something you do all day, every day. I'll share a little bit about the evidence and what's happening with it. And then I'll tell you about how SPANYA came to be and what we're hoping to do with this study. So many of you have seen my talks. You know that I, as a qualitative researcher, feel pretty strongly about the idea that I need to kind of offer a little bit of disclosure about who I am and what I bring to the work that I do. And today I'm going to kind of expand those disclosures a little bit more, even to share a little bit of my story and explain this journey that I've been on. So I grew up in the beautiful state of New Mexico. It is an incredibly complicated place. There is amazing history there. About a third of the state is Navajo Nation by land mass. Most of the state is incredibly rural. The Catholic Church plays a huge role. There are 2 national labs, a lot of science, but also 2 very large Air Force bases that really are a big presence in the state as well. So it's culturally very mixed, it's politically very mixed and complicated, and it is incredibly impoverished. And while I was growing up there were some very significant health and public health challenges there. And there were some things that really scared me about growing up in New Mexico. In particular, there was a huge amount of community violence. So I probably should have been even more scared about this than I was. I'm going to show you some statistics from my freshman year of high school about what the demographics in the state look like for different public health concerns. So at the time that I was growing up there, New Mexico had one of the highest teen death rates that included accident, homicide, and suicide. As a qualitative researcher, I think stories can be powerful. So, for example, I'll share that we had a triple homicide a block from my high school campus, in which one of the people from our homecoming court was killed, which was working as a clerk at a video store, right? And that was just really normal. We had a moment of silence every year at graduation for all the kids who died. And I genuinely didn't know that that was abnormal until I got to college. I thought everyone had that. What scared me most, actually, was the possibility of pregnancy. We had an incredibly high teen pregnancy rate while I was growing up there. It was a place where we had a daycare center on our high school campus in an effort to try and keep kids in school who were pregnant. And I really saw this as kind of the end of a life. if you got pregnant, you did not have to do anything. And I was perpetually terrified of pregnancy or anything else that would cause me to have to drop out. And in retrospect, this actually makes sense. I was going to high school actually at about the peak of dropout rates in the United States in recent history, and they were particularly high for Latinx populations like myself. So, these years, they felt that I spent a lot of my early adulthood wondering if they were kind of overly inflated, but in going back and doing this quick public health survey for this talk, I realized it actually made a lot of sense. It was pretty right to be worried about these things. And it was very much just a reality that we were faced with as children. On the first day of high school, my high school principal told us, we were all lined up in the stadium, he told us, look to your right and look to your left. Half of you will graduate and you have to decide which half you will be in. And at the time, this made total sense to me. I really grew up in a world where, you had to take charge of yourself. And, of course, there's some truth to that. But as a pediatrician and a public health researcher at this point in my career, this statement is actually pretty horrifying. It is incredibly unfair that children were being asked to face these completely insurmountable public health challenges individually. And I didn't have words for that when I was in high school. I didn't know terms like public health. I didn't know terms like structural racism. But my sense was, holy crap, this is really, really broken. And I really wanted to do something to fix it. And so I decided I wanted to be a pediatrician. And honestly, it was because of my sense that pediatricians had some amount of power and privilege. They always had food on their table. There was no worries about money if you were a doctor, right? All of this sounded great. I was going to be a pediatrician and do something. I wasn't really sure what. And so I essentially ran away from home to college and had an incredible culture shock in getting to MIT. I was very grateful that they had a pass no record system for freshmen, and I sort of got my feet under me and managed to get through. And then began learning about what it is to be a doctor, about what public health is, about those potential tools that I might accumulate along the way, qualitative research, health, and landed at UCSF with some pretty big aspirations as a fellow here in health policy and adolescent medicine. So when I came to UCSF, I had some basic plans. I was going to fix teen pregnancy, promote adolescent and reproductive health, partner with communities of color in research, and understand the biggest challenges to adolescent and adult health in those communities. Charlie Irwin interviewed me. He can tell you this was my plan. And I was like, 3 years, I should be good. Well, very lucky for me. Teen pregnancy was the main thing that brought me into adolescent medicine. It was a big project and mostly done by other people by the time I got here. You guys know and love Brenda's, as do I, and many other people in the division who have done very hard work to address rates of unplanned teen pregnancies. And so this graph shows you where things were when I graduated from high school in the late 90s and where they were by the time I matriculated to fellowship in 2012. You can see the curve is already really moving in the right direction, thank goodness. I was still really interested in promoting adolescent reproductive health, and this has become a huge part of my clinical work and my medical education work. Right now, for example, in our clinic, we recently rolled out medication abortions in our adolescent and young adult clinic. We're creating a curriculum that we're hoping to leverage nationwide for adolescent physicians. So this is still a big part of what I do. And I've also remained really committed to partnering with communities of color in my research. And in doing that and going to those communities and asking about the biggest challenges in their adolescent and adult health, I've been surprised at where my research has taken me. It's not landed where it's. So just a couple of snapshots of prior projects on this journey. When I was a fellow, I got to work with Claire doing a community engaged study with young people who were eligible for DACA. At the time, this was very cutting edge. DACA was incredibly new. And we did focus groups in Northern and Southern California. We were working with an advisory board, and we really focused on understanding their healthcare needs and their healthcare experiences. And this was even before Medi-Cal was available to these young people. So they were really in a very different place in terms of healthcare access. And then my bigger project that I've been working on for many years now is a community engaged research study down in Salinas, California, which which is a small urban center of a much larger agricultural region. Most of you probably know this is where your strawberries come from, your lettuce comes from, your kale comes from. And we've been doing this community engaged study down there since 2015, heavily driven by the community. That actually started when one of the people at the health department down there approached one of my co-investigators to say, you're studying community violence and gang violence and reproductive health in San Francisco, but we want to study that. We have all those problems too. And we've been working with a community advisory board of 15 to 20 youth serving organizations and youth advisory boards since it started. And we've been following a cohort of about 600 youth that we recruited originally in 8th grade. Like their community, they're 94% Latinx, about half female. And we actually have an RO1 now to follow them into young adulthood. So we're in the process of re-enrolling that cohort and reaching out to them to find out where things have taken them. And the bottom line is that in these kind of different bodies of research, as I reached out to youth, to parents, to educators, and to community members, they were all very clear. I always went in wanting to talk about teen pregnancy, and they always came back to me wanting to talk about mental health. Mental health was the primary underserved need for adolescents and adults in all of these communities. And we were really seeing similar things nationally, right, at around the same time. We've seen that treatment of mental health concerns was increasing in pediatric and adult primary care populations throughout this period of time into 2010 into the mid-2010s. Pediatricians were actually writing more psychotropic medications for psychiatrists for adolescents by 2010. And pediatric ER visits for mental health were also rising steadily even prior to and this is what we were seeing within our clinical practice too. I've been lucky enough to practice at UCSS adolescent and youth adult clinic. We serve, as Mara mentioned, 12 to 26-year-old patients in primary care and specialty care. What does specialty care look like for these young people? Reproductive health, mental health, eating disorders, substance use disorders, sometimes some sports medicine, other things. And within my clinical practice, my colleagues and I really started to see substance use disorders rising. One of my incredibly talented colleagues, Veronica Sherikova, started a youth substance use disorder program, one of the first in the country. Our clinic also began to see an uptick in our patients with eating disorders. This little graph here on the side shows you that from fiscal year 17 to 19, we were already starting to see a pretty steady rise, hence about the doubling of the number of patients who were in our hospital being treated for medical complications of eating disorders. And we were also seeing anecdotally that it's really difficult for some patients to access mental health services, especially those who are publicly insured or non-English speaking patients. And so I started to pivot. I became a mental health researcher. And in our UCSF eating disorders patients, we found that almost half of our patients are actually non-white. I think it's really not what people expect when they imagine patients with anorexia nervosa. Our patients who are privately insured was 3 times more likely than our publicly insured patients to get the mental health care that we were prescribing for them. And white patients were twice as likely as Latinx and Asian patients to receive the appropriate specialized mental health care. So we've seen even in a place like UCSF where we actually have many more resources than other communities, and where the surrounding community is really willing to work with us to try and look at opportunities for our patients to access care, is still really there are still really significant barriers. And this was before the pandemic, right? This is then the pandemic. And I know that everybody has heard about the mental health crisis during the pandemic, but I really want to emphasize that the rate of acute care visits for eating disorders increased more than any other adolescent mental health condition. There's been so much published about depression and suicidality. And just to drive it home, here's sort of a table from a recent paper looking at the percent change from baseline to pandemic's year 1 and year 2. For year 1, almost everything dropped off, right? Because no one was coming into care anywhere. And then by year 2, we start to see the impacts. And you can see down here at the bottom, eating disorders increased by 120%. 120%. Suicidal ideation and suicide attempt increased by 44%, and eating disorders increased by 120%. And we were seeing this in our hospitals. So you can see this increase and our rates of inpatient daily care for patients with eating disorders. Our census has gone up to an average of about 8.5 patients a day. And it's plateaued there. We all hoped that it would go down after the pandemic, and it is not falling. It's really quite stable. And this was overwhelming to our entire field. This is not a UCSF phenomenon. This is actually worldwide. There's data from, or at least developed countrywide. There's data from the UK. There's data from Australia, and this is a very widespread phenomenon. And it's almost logarithmic in our outpatient visits. We would be admitting more patients, but we can't. There's only so many beds in the hospital. We have to admit patients with other indications as well. But our outpatient visits skyrocketed. And this was huge. It really overwhelmed our practice for a while. It was pretty much what we were doing. And, I really want to emphasize a little bit just about eating disorders and anorexia. Eating disorders are incredibly common. The prevalence is probably increasing, but best estimates are that at least 9% of the US population will have an eating disorder in their lifetime. And anorexia nervosa is the eating disorder I'm going to focus on because it is one of the most medically dangerous eating disorders, one that we treat very often. Its core features are restriction of energy intake that leads to weight loss, intense fear of gaining weight, or a persistent refusal to gain weight when a patient needs to. We see this sometimes when patients are in the middle of their growth spurt and they plateau, but they need to be gaining weight. They're not keeping up with their high acceleration. A disturbance in experience of body shape, or a lack of recognition of how serious their well-being is. Core features of anorexia. And anorexia in particular, and eating disorders in general, can lead to severe medical, psychological consequences, including death. A patient dies from an eating disorder in the United States every 2 minutes. This became very salient to me in the middle of the pandemic. We had patients pass away. We are usually able to stabilize our patients. Our patients usually, once we have don't die. But we did have some deaths of patients at home during the pandemic. And when I am having trouble focusing on my research, this is what I bring to mind. So anorexia itself has somewhere between a 6 and 10% mortality rate. And again, just to drive home how deadly this illness is, that's twice the mortality rate of schizophrenia and 3 times the mortality rate of bipolar disorder. The only thing that arguably has a higher mortality rate is substance use disorder. It has a higher mortality rate than ALL, the most common form of childhood cancer. And we have been making treatment strides in ALL steadily for decades. And we really haven't had any breakthroughs in anorexia. There are also other devastating long-term outcomes for those who don't die. Less than 50% of patients with our current treatments fully recover. 20% remain chronically ill. 20% are unable to support themselves as adults. These are really devastating outcomes. And eating disorders begin at birth. Peak incidence, we thought, used to be around age 15, but our current studies are showing that it's falling and maybe as low as 12 years old at this point. There's definitely an increased frequency in 10 to 14-year-olds that's been clearly documented across multiple studies since 2008. And it's not totally clear if this is an earlier onset. Some people use media, it's definitely multifactorial, or if it's just about earlier detection. But what we do know is that during the pandemic, patients started presenting younger and sicker than they had been. We were seeing increased incidence of suicidal ideation and attempts, along with those eating disorder presentations nationally. And anecdotally here at UCSF, we've also just had more patients in the ICU than we've ever had before. They presented very medically illness. And this matters, this early onset, because adolescence is this really critical period of growth development. It's actually happening between sort of your, between the end of puberty and your mid-20s. Is that your brain is changing a bunch. It's grown about as much as it's going to grow, but it starts doing what's called pruning. It starts reinforcing the pathways that you use most and trimming away the pathways that you don't use. And this really matters if you're a young person who is stuck in a pattern of mental illness or addiction or using other maladaptive coping strategies, because those are the pathways that get reinforced. And it's very important to provide a counterbalance. And there is good data that shows that sort of strategies like promoting social connection can actually change some of these pathways and promote other more positive forms of literally neural development. So what do we have right now for anorexia nervosa? Our gold standard therapy is something called family-based treatment. It empowers families towards weight restoration with a really agnostic view of what caused the anorexia. We do not believe that parents cause anorexia. We believe it's very multifactorial. There are definitely environmental and genetic components. But we do know that families can, in some circumstances, refeed their kids and help them through it. And this is the best we have, and it creates sustained remission in less than half. It is incredibly taxing on families. It requires parents to usually take significant time off of work to feed their kids up to 6 times a day. And there's not very many providers who are well trained in it. And so it's very hard to access, and finding language support providers is incredibly challenging. I always, when I meet a new family, explain to them that this is a war lost in the bread crusts. Every bite counts. Your child has an illness as fatal as ALL. We really need you to engage. And actually, Charlie Irwin shared this anecdote with me of something that one of the family members said back to him. He said, "No one asks parents to give children chemotherapy. What we're asking of these families is just huge." I wish that we had other things to offer, but unfortunately, to date, medication management of anorexia has really not shown significant promise. There's no medications that have been proven to reverse its core symptoms. Second-generation antipsychotics have a little bit of help with symptom management, but it's very hard to get patients to take them long-term at all. There's a little bit of evidence for SSRIs to reduce particularly binge purge cycles, but it is also not great and doesn't have any more effect for anorexia nervosa, especially the restrictive side. So where we landed with the pandemic was this perfect storm, right? We knew that there were mental health problems prior, and we knew that things were worsening. We knew that it was hard for our patients to access care. And then there was this huge surge in the pandemic. And it's easy to talk about statistics. It's easy to think about those things, but the reality for each of these patients is that we need to get them into care that actually changes their disease course within 3 years, so that they are less likely to have poor outcomes. We have a 3-year window for patients to really change their disease. So, we talked about big statistics, but I'm a qualitative researcher at heart. So I'm going to tell you one patient story from one of my days on service. I was on service in March of last year and taking care of a girl who really wanted to die. She was in our hospital. She was malnourished, and she really wanted to die. She did not want to eat. She wanted to die. And because our job is to keep our patients from dying, and her heart rate was low, and you must eat to live. The only thing that we could do for her at that point was to place the feeding tube to help her take in nutrition. And with her parents' support, we initiated that plan. And she wanted to die so much that I was in the room with her and 6 nursing staff to try and support her to get the NG tube in. That tube was placed, and she wanted to die so badly that she coughed it up and bit holes in it. And it was a moment of total powerlessness to me. I just genuinely did not know what to do for her. I know how to keep kids safe in the hospital, but only if I can do that. And I don't have a lot of other options after this. And it was very striking to me. I mean, this is in this setting of this tidal wave of other patients, 15 other patients, 14 other patients right there taking care of in that moment. And what I know to do when I have one of those moments of utter powerlessness, the thing that I come back to over and over in my life is this mantra. I ask myself, what power and privilege do I have? And am I using it to the best and right? And at this moment in my practice and in the world, the thing that I kept coming back to is these crazy studies I was hearing about from other colleagues at UCSF. Right around this time, Josh Lee and his group had put out the results of a study that they did on PTSD and MDMA. And that study showed what literally seemed unbelievable to me. After 3 doses with therapy support, these patients who had PTSD for 18 years, the majority of whom had been suicidal recently, no, 2/3 no longer met criteria for PTSD at the end of the study. Wild. We don't see things like that in behavioral health. And then the 1-year follow-up, the numbers went up, down, right? In mental health, we always see regression to the mean. Having some intervention is amazing, and it helps people for a while, and then they fall back. But the study, it wasn't showing the fallback, right? Do you see that? And as I was learning about these studies, this is what was going through my mind in that patient's room. What was going through my mind is, am I using all of my power and push to do everything I could for this patient? We tried this. It sounds so crazy. It sounds unspeakably crazy. And so what I did was I went to lunch with a colleague, mostly to process my incredibly strong feelings about this case. And I talked with her. Her name's Sarah. You'll see her in a moment in another slide. And she's a therapist in our program. And I told her, Sarah, I have this completely crazy idea. I just need to speak it aloud so I can let it go. I keep thinking about doing a study of psilocybin to treat our patients. And Sarah's a great psychotherapist. I expected her to say something like, fantasy is an important part of coping or something like that, right? But what she actually said is, I know how to do therapy and you know how to do research, and we have to do that trial. And that was kind of the seed where SPANYA began. And I have to tell you, I told Sarah, I don't know how to do that kind of research, but we've been figuring it out. So this is Sarah and myself, and we started talking to other people. I approached Amanda Downey, who's the assistant director of our eating disorder program, and an incredibly talented triple boarded physician. So she supported in psychiatry, child molestation, psychiatry, and pediatrics. And her response was, yes, this is why I came to UCSF. And I talked to Sarah Buckley, the head of our eating disorder program, and she said, that study has to happen. Of course that study would happen. And so we pulled together a team of people in our eating disorder program who were really excited about the possibility of doing this research. And began to think about what it is that we knew about psychedelics and eating disorders and where we might take this research question. So I'm going to teach you a little bit about a typical psychedelic therapy trial and how they're put together. There's always, of course, a medical and psychological screening phase. The patients have what we call preparatory therapy. This is kind of getting them ready, helping them understand what to expect with the psychedelic therapy, helping them understand what being on a psychedelic medication might feel like, helping them essentially set some goals. We call it creating an intention. And then there are dosing days, and most psychedelic studies have anywhere from 1 to 3 dosing days. And these are intense. These medications last a long time. Depending on the medication used in the trial, it's anywhere from 4 to 8 hours of active medication. And that is a full-blown trip, a full psychedelic experience. And patients in these studies are, the standard of care is to support them with at least 2 people on the dosing day. For a couple of reasons. It's a very intense emotional experience for patients, so it's hard work with therapists sometimes. And it's also just a really long day. You can't leave someone who is on a psychedelic alone. And so therapists need to take breaks, they need to go to the bathroom, they need to eat. And then the last reason is for patient safety. Right? This is a very vulnerable state for a patient to be in, and so you want them to be supported and to make sure that no one is taking advantage of them. So they have their dosing day, they have what we call integration therapy, where they begin to make meaning of that experience. Another dosing day may be integration therapy for a total of 1 to 3 dosing days.
I'm sorry, how much of the course time should
it depends on the medication, but anywhere from 2 to 4 weeks. So these studies are often as short as 12 weeks, 8 weeks, short interventions. And as we started to put SPANYA together, we really zeroed in on some elements for the study that were really important to our team. We decided to focus on 18 to 25-year-olds. Remember that they're still in this window of critical neurodevelopment, and we really wanted to begin to ask the question, what happens when you give these medications to develop? We know from the rest of our treatment in eating disorders that families are really crucial, and we see in our young adult populations, they still really rely on them. Remember, many of them are not able to earn a living to do this. We had a lens towards equity. as Claire told me at one point, you are still new when you do this research. So when I came into this, I said, we're going to do it bilingually. I'm still shocked to say that we are the first study that I know of in the United States to do this work bilingually, despite the number of trials that have been done. And we really wanted to develop approaches for collaborating with community therapists. I show this graphic to people, and everyone in this room is going to look at that graphic and say, like, of course, because we're all public health oriented, and you can see like everything looks like the sociological models, right? But when I take this into clinical trialists, they're like, what is that? And it seems incredibly novel and fascinating to them that our study would remotely think about these other things. It's a lot of fun. So there was very little prior research when we got started. I put this slide up mostly to emphasize the white, all of the places that no one had been asking questions, but they were interested. And we had to decide at the beginning what medication we were going to use. I'm not going to go into great detail about why we chose psilocybin in this particular talk. I'm glad to nerd out about that with anyone who wants to. But it looked like the most promising. It's a serotonergic medication that overlaps with anorexia, and some of the least work that's done with it. So I will share, I won't go into a lot of the biologic details, but I do find it helpful to share a metaphor that's often used in discussing psychedelics about why they can be very effective. And I think there's a lot of skepticism, understandably, about any new medication that people are touting as helpful across multiple indications. And one of the reasons that we think that psilocybin and MDMA and other psychedelics might be helpful across multiple indications is explained well by this snow globe metaphor. So the idea is there's a neural pathway in the brain that you can watch on fMRI called the default network. And this is kind of, you can think of it as where your brain spins when you're not asking your brain to do it. So if you're a busy mom like me, it's like this checklist of like, did I reserve the park for the birthday party? Did we make sure that the babysitter's coming next week? Who's going to make lunches tomorrow, right? But for my patients who are depressed, it might be, I'm worthless. It's never going to get better. Life's not worth living. For my patients with anorexia, it might be, I'm fat, I'm fat, I'm fat. The default mode work gets really stuck across a variety of severe and enduring mental illnesses. And that's actually the main mechanism for these medications. One of my colleagues here at UCSF said that when you take a psychedelic, it's like normally you have these like really stuck ruts in the snow, right? Where the slide's been going over and over and over, default, whatever. I'm fat, I'm fat, I'm fat, I'm fat, I'm fat. And a psychedelic shakes the snow, right? And the snow is all of a sudden it's released from those really stuck places. And then you have this window as the snow resettles to try and figure out what interventions you're going to put in place and how you're going to change things. And that's why it seems to work across so many different mental illnesses. And it also is probably why we continue to see improvements in some patients after the clinical trials. If you can get them into a therapy environment or other environment that continues to allow healing, that snow will continue to settle in different ways. So we had this great team. The one problem was that no one on this team actually knew how to do a psychedelic, but I tried. So great news was we're at UCSF, where collaborators are phenomenal, and you can cold call people with crazy ideas. So I began reaching out to people across UCSF, our team motto at that point was, you can help us or get out of our way. We were very determined. And so I was just reaching out to anyone I thought might be willing to teach me about how to do clinical trial, because I didn't even know how to do it. Really clear. Okay, so after reaching out to a few people, I met Josh. And Josh's response the first time I pitched the study to him was, this is why I love this place. And he was, really excited that we were excited. Josh is a PI of a group called the Translational Psychedelic Research Program. Acronym is TRIPPER. Yes, TRIPPER. He's a funny guy, he's lots of fun. And he really does trials in patient populations that other people won't touch in the psychedelic. He's doing trials in patients with Parkinson's disease, with bipolar disorder. A lot of people worry about that coming in. With methamphetamine use disorder. He really believes that people who have severe mental illness should have access to trials. And so I met with him once, and then I asked him to meet me again and again and again. And he was kind of like, wow, you like really want to do this, don't you? I got to meet you in person, is what he said finally. After the fourth or fifth time, I asked him to explain things to me on Zoom. And so, as many amazing ideas in San Francisco are born, we met for tacos in the outer sunset. And I just made a total gut wrenching appeal to him about what we were seeing in our patient population and how badly we needed to do this study. And what I wanted to do, the team who was coming to it and our willingness to put in blood, sweat, and tears. And by the middle of lunch, he was like, I get it. Okay, we're gonna do the trial. We're gonna figure it out. And so Josh joined our team, and he brought with him an incredibly talented group of people at Tripper. I only have room for a couple of them on the slide, so I'm going to emphasize Gisela, who is his lead psychotherapist in there, who is also helping our eating disorder therapists get up to speed and create a protocol that's appropriate for our patients. And so with this, we kind of were ready to move full steam ahead, and that's when I had my mini career crisis. And I was like, okay, I had a little bit of funding left from a Watson Scholars fund that I had access to. We were really going to go, and I called Claire, and I told Claire Brindis, "Is this insane? I did not come here to do this. Is this health policy? I'm a faculty member in IHPS. Is this what I'm supposed to be doing?" It was genuinely a career crisis for me, and I was very scared to actually move forward. I had incredible imposter syndrome moving into this space, but there was also some identity issues. And as I talked with Claire, I came to recognize that it wasn't just like, was I hired to do this? But there was also this core question of, what will people think of me, right? Because I grew up where we started, right? In this like highly policed world, in the middle of the war on drugs. I was literally DARE student of the year in 5th grade. You guys remember DARE, right? So this was actually quite hard. It was an old hang up, and it was incredibly hard to start talking to people about doing this study. I remember coming to Charlie. I was terrified to talk to the head of pediatrics about it. I was like, these guys are going to think I'm nuts. But actually, our chair's response was, I read about that in the New York Times. He was really enthusiastic about it. And I began to sort of calm down. But I think this question is really important, and it continues to inform our study development. What will people think of me? Because I anticipate that these feelings might arise in potential research participants, in their family members, and referring providers, right? These medications have been heavily stigmatized, and it will be a lot of work with community engagement to surmount those barriers, especially if we really want a diverse patient population in these studies. And that's what brought me to starting to think about this from a stakeholder perspective. And so I'm going to share with you some results of a set of focus groups that we did with eating disorder therapists and physicians. And we'll go through this a little fast. But, I don't need to tell you guys about the utility of stakeholder engagement. And there was a little bit of data out there already of a kind of quantitative survey about general psychologists and how they felt about psilocybin. And 77% said they'd tell their patients about it if it was FDA approved as well, if it was FDA approved questions. But 37% said they would still be reluctant to recommend it. And 3/4 said that having more knowledge or experience with it would increase their likelihood. So we became interested in doing focus groups to kind of understand within the world of eating disorder providers, what they know about it, what were they concerned about, and what information would help them kind of open their minds to their patients accessing this. So we recruited doctors and psychotherapists across California who self-identify as people who take care of patients with eating disorders and have a particular focus on that. And we did 5 focus groups with them across California. And as I mentioned, we kind of talked about their knowledge and attitudes, information they would need to feel confident referring to a psychedelic therapy trial, trusted sources of training that we could do outreach to them, to that group about in the future, and feedback on our study design. We had 4 team members who have helped them with that. So there was a lot of hope and cautious optimism. One provider said, I'm hearing from people who get stuck. Like, we all want more tools to help. And so I'm so open. If there's something that can help, like, I want to know what that is, and I think we should explore it. But we also heard a lot of equity concerns, some worries that there wouldn't be real access based on differences to economic status, access on there's access for all of the different types of anorexia nervosa, those who urge, those who start at higher rates. One participant said, the people who are going to start are the people who can afford it. It's not fair because it's not going to be available via insurance for quite a while. So, heard about concerns about patients' perceptions. If patients might be averse to using the drug, families could be concerned about addiction, may see two alternatives. One of the therapists said, my initial thought is, how would I introduce this to a client? I can see some clients, especially natives of the Bay Area, being like, yeah, this is great. I can see others who are literally saying to me, this seems a little bit too. And actually, this really surprised me. There's a lot of worry about liability, about their own liability in their practice if patients have negative outcomes. I do worry about adverse events. We know that out in the real world, people do have really negative experiences with some of these substances. And so just never wanting that to be under our care because of something we recommend. And we asked, what do you need in terms of collaboration after a psychedelic? And what they asked for was a patient prepared written summary. They really wanted, as a research team, for us to do something that the patients could take with them back into their psychotherapy in the long term, so that there could be some shared understanding of what the psychedelic therapy experience was like for them and what their goals are as they move forward. Remember, they're one of the groups that was going to help that snow continue to set. They asked for a verbal handoff from our study team, and they asked for the option of ongoing consultation for a few months after a patient exits the trial. As an outpatient therapist, I'm going to want a little more hand, kind of knowing what to expect, more collaboration in terms of how to coordinate care coming back into treatment.
Can I just clarify, patient prepared written summary, could the patient also just talk into a recording and then they can listen to it, just to go back to this FDA issue?
No, I think that's possible. It was something that we were actually going to structure into our integration therapy to work through with that. And I think we're still figuring out exactly what that will look like. I think for some patients, they need the structure. There might be something as small as handouts. For other patients, if they have their own process, it's fine. But it's just something that allows them to think about, and our integration process in general will include that question about therapy and out family. What support do you want? The therapists and physicians also wanted more continuing education. They wanted to know about psychedelic therapy integration. They wanted a repository for updated resources. One of them said, I would like for you to educate so that I can hold this better for them. I hope that would be something that we can have access to because in this journey. And my favorite summary quote from all of these focus groups was this: I will be part of the team whether I'm on the faculty. In my viewpoint, I need to be on the front end. These therapists are going to be referring to us, providers referring to us, and they're going to be accepting patients back into care. And we really need to think about that as part of this. So we have made some changes to SPANYA as a result of this, and I mentioned we have this participant created summary that we're working on. Our therapists will be offering to do a verbal handoff with our patient therapist at the conclusion of the study. We are curating most of publications and resources. And we're beginning to do some formal CE programs. We just actually applied to do a workshop at SAM this year to introduce goals. And a brief other couple of notes about our community engagement. We are developing an advisory board. I've never done a study without an advisory board, and we're not about to start. And we're hoping that this advisory board may also be a model for some of the other studies in Tripper to begin to think about how they can integrate more patient and community perspective. We're going to be including young people with lived experience with anorexia nervosa, but who are not research participants currently. We just want to make sure both that we're not creating, and who wouldn't be eligible for this study. We want to make sure that we're not creating dual roles that would be complicated, and also sort of any expectations that if you're part of our advisory board, you will definitely be the study, for example. So we're largely recruiting from patients who have either recovered or who have graduated from our program and would be able to the study, but looking for adjacent people. And then similarly, family members who've supported young people who are not eligible for the study. And right now we're anticipating quarterly meetings. And we already have a whole list of things that we want to talk with them about. As a very concrete example, we're worried about hypoglycemia in our patients. We need them to eat while they are treating. And so we're trying to figure out how to do that best and how to talk with them about it. right now we will probably offer them more slow milk to drink throughout the day, but how do we make that as manageable as possible for them? How do we create the alliance around it? So just things like that are the sorts of things that we're going to take to our advice. We'll be doing exit interviews with all of the young adults and their parents with a focus on how the studies impacted them, what was helpful, and what we can improve. We see this as the first of what we hope will be several studies in this space. And then I know this sounds weird, but as I mentioned earlier, the NIH is not funding this work. So we are actually funding this entirely through philanthropy and the RAP grant. And so I've been meeting dozens of families who are supporting this study. And I'm very aware of the fact that these are a very privileged subset of families with anorexia who can afford to donate to the trial. And it is still been a very remarkable and unique experience to meet with these families at very different stages in their children's healing. Some of them are very actively ill still, and hear their stories and involve them in the study and hear from them about the study design. And I'll share one quote from them. She said, "I don't have power in privilege. You have power. You can do this study. I don't know what else I can do for you." So these are, I think, non-traditional and heavily skewed, also important voices and perspectives who are engaging with the study and making it possible. And we've actually raised about $1 million from that plan and matching other. So in terms of next steps, we are in the process of launching one more. Okay, this was the last slide I wanted to share with you guys. See that, which is just a little bit about this idea. On average, it takes about 9 additional years from a novel drug from approval in the adult population to approval in the pediatric population. And every one of these years is a year for the patients. I just want to come back to that every 52 minutes. 9 years is way too many 52 minutes. And this isn't what the FDA wants either. The FDA has actually really put out clear positions on the fact that they want to see parallel trials in adult and pediatric populations, especially in life-threatening illnesses. And so our group really wants to be prepared to study these medications in young populations specifically. So with that, I will examine this speech and glad to take questions. You're able to see questions.
Yeah, we can. So we'll alternate if anybody on Zoom has a question, they can just put it in the chat.
Yeah, go ahead.
Hi, thank you for your important work and thank you for your important work. So I had a question. I was thinking that part of the bias you're running into psilocybin is because of the war on drugs, right? And so I just wanted to encourage you to consider writing an op-ed about how the war on drugs is like impacting treatment options. And we have a lot of we have Louise Aronson here at UCSF who is probably and I think in IAPHS, I learned about her when she spoke here, so I think that's probably recorded. She was really helpful.
Yes. Can you tell me her name one more time?
Louise Aronson.
Louise Aronson. So the suggestion was write an op-ed about how the war on drugs is impacting access to care and access and patient access to clinical trials. And I think that's a great idea.
What's kind of the legal or regulatory environment and trying to do something like this? Because you already have IRB and FDA approval, and I would.
We're
think
waiting for
it's-
FDA approval. There are at least 3 regulatory agencies within California that have yet. So there's our IRB. There's a group called RAPCAL, which is a state regulatory body that has to review several one substance clinical trials. And then there's that. And so we are waiting on FDA now.
Is there a difference between state and federal level in terms of resistance to?
You know, I mean, I imagine that California is an easier place to do this than many places, if nothing else, because we've had a lot of clinical trials already here. And I think they look for different things. You know, so you kind of heard that one is more picky than the others. They're going there first in the hopes that that makes things smoother. I think they just look for different things a little bit. I think these studies are very confusing to people. I've heard people say that there's sort of too much drug in them to be therapy trials, and there's too much therapy in them to be drug trials. I do think it's really, really important to emphasize we are not testing psilocybin. We are testing psilocybin-assisted therapy. I do not believe that just giving a patient psilocybin will necessarily help them. I think it can lead to very challenging experiences. What I will say, the other thing that I didn't present from our focus group study is that it is very clear to us that patients are accessing these medications in out-of-group ways. It means are traveling to other countries. People are accessing them underground. They've been criminalized in some areas. There's a lot of variability in terms of people using those substances with trained mental health providers and experienced guides versus just using them on their own. And the experiences can be very different. But the incredible results we're seeing are from these structured clinical trials that really provide guidance and support and help people prepare for difficult experiences and make sense of them.
Any questions on this one? Can I just ask,
Yes.
so, some kind of basic question, but maybe a bigger picture question, how many people are you enrolled in the trial?
We're still fundraising. I'm hoping we can definitely do 20 right now, and I'm hoping to do 40. We could make it for all of this.
And do people usually do control groups?
Oh gosh, that's a great question. So there have been so many attempts to control for these study designs, and I can nerd out with you a little bit offline about this, but the answer is there's been no placebo that actually seems to blind both, because you need to blind both the patient and the therapist essentially, to have it be effective. And there's been no placebo that is effectively blind. We have some other specific trial design ideas that we are making very public, but I'm happy to chat with you about them. But that we think will help to mitigate.
And for the advisory board, these kids are actively sick. Are they gonna have access to, like, I can imagine the complicated benefits, the same question for them.
Well, that's what
Oh, sorry, not the advisory board, the donor families.
Oh, the donor families. It is a bit complicated, and we've been very clear with them about the fact that we can't guarantee that their kid would even be eligible.
Right.
You know, and eligibility is so dynamic, right? They have to be stable, like medically stable enough at the time. Dosing to be considered, that kind of thing. And so we're just very with people, and they've been very understanding about that. And there is a percent of people come through the program. Some people are still very much sick of it.
Question from Zoom from Sharika Langsberg. Could you share again what month in 2024 you anticipate enrolling participants? Will use of fluoxetine or antipsychotic medications be an exclusion criteria?
Great question. So, I am hoping that we will start enrollment in March. We'll have to see exactly how it goes, but that's what I'm hoping. And serotonergic medications are likely to blunt the effect of psilocybin. And so for multiple patients, what we're going to do is work with our psychiatrist, Amanda, to titrate them off. And if you can be off them stably, then there's only been one, there's like a theoretical risk of serotonin syndromes, so that doesn't seem to be bearing out. There's only one preprint out there right now that's really looked at this in one small trial for depression. And it looks like it just lends the effect that there was increased risk for serotonin syndrome, but that's one of the theoretical warranties. So we are not going to exclude patients who are on those medications per se, but you do need to be willing to titrate them off and tolerate the titration to proceed.
Just had another comment on your slides. I thought they were great. And I really liked the table that you had where you showed the holes in the literature. And I think I might incorporate that into grant applications. Like that is great, right? Like to visualize where all the holes are. I just thought it was great. Yes.
Any final questions from the Zoom? Oh, one more. From Abigail Aarons, you mentioned needing safety and responsibility to enroll pediatric patients. What are some of the barriers you have to enroll pediatric patients, and where are these barriers coming from? IRB, FDA, etc.
So I think what I didn't go through in great detail is that I have at this point a very good sense of the landscape of ongoing clinical trials. And I think that probably the biggest barrier is within our IRB to demonstrate that we do have at least some safety and efficacy data. I think it's important to remember this is a very medically sick population, right? It's very medically. We're going to be enrolling patients down to a BMI of 12. And so we do want a fairly good, our feet under us in terms of like those aspects of safety. And then we do want to at least get through most of the other trials that are happening are with older patients, 40s patients who've been ill much longer. And none of them have the substantial family component that we're building in. But for kind of what we need, I think, to move forward, I think we need some of those trials that are showing some really promising results to come out and to demonstrate safety. One of them came out about 2 weeks ago with 10 patients from UCSD. So I'm waiting for those to come out and probably for like our first few young adult patients to be dosed and to be able to sort of show that our first 10 patients are doing well. And then I'm very interested in opening it up if we're able to sort of show higher data to support the safety and that things look safe for patient population. I really see this as like an ethical imperative, and because you know patients, like young patients, are accessing these medications at the ground, and I would rather them do it in our clinical trial. But that's a hard sell for them. And so, but I think these are genuine things that we're weighing. I also think that there are cognitive limitations to how young a patient can be. You really need to be able to have a lot of abstract thinking and to engage in a level of metaphorical meaning making to get something out of these experiences. And so I don't think it's something we will ever give to young adolescents. And my real question is like 16, 17-year-olds. Maybe even the right ones, right? And like, how do we figure that out?
Well, thank you so much. Absolutely fascinating and such important work. Thank you to everybody on Zoom and everyone, and appreciate it. One final round of applause.